Good afternoon, and welcome back from your breakouts and break-ins. If you learned something today in your breakouts that you can take back and immediately start using in your work as soon as you get back, signify that with your applause. Awesome. I saw the rooms were filled. You guys were in there, and you were in your posture. You assumed the position, and I thank you for it. We are in the final push for today. And as we do, I have a few announcements to make before we bring up our closing speaker for today. Couple of things. Tomorrow, how about if I start with today? After this session, it is still not done. We are going to be partying Texas style. We have a reception, a networking reception. So bring your new friends, bring your old friends that you have met here over to the Hotel Contessa, 300 Market Street, just 2 blocks from here, 6 to 8 o'clock for our networking reception. Tomorrow, we will be having our best boot contest. So make sure that you put on your boots and bring them here and show them off for the contest tomorrow. Tomorrow morning, we will be starting again at 8:30 in this room, and we go until 3 o'clock. At 2 o'clock, it is not just closing remarks because you have met me, right? So you know we are going to be engaged in some active work to prepare ourselves for what we need to do to put this learning into use and into action immediately. So make sure that you have scheduled to be here all afternoon, right up until 3 o'clock. Okay? Tomorrow morning at 6:30, once again, you will have an opportunity to join San Antonio Walks for a walk on the Riverwalk. And if you haven't had a chance to do that yet, because I ordered conference weather for this, the kind of weather that keeps you in the conference center, okay? But tomorrow morning, there's supposed to be a little bit of a break in the conference weather. So if you would, at 6:30 a.m., like to meet in the lobby of the Hotel Contessa, you'll get a chance to see the beautiful San Antonio Riverwalk. And the walk is led, San Antonio Walks is a nonprofit organization that contributes to your health with promotion of healthy walks like this. So it is a led walk on the Riverwalk. So 6:30 tomorrow morning in the lobby of the Hotel Contessa. So, but don't let that stop you from joining us tonight at the reception at 6 p.m. to 8 o'clock, also Hotel Contessa. So, to close us out this evening, we had got to hear some of the statistics around many of the diseases that are still in play, that we're still trying to work with in our efforts for a vaccine-preventable free world. And one of those was pertussis. You're going to hear more about that this afternoon. To help bring up our speakers, Anna is going to come up and start us off with this evening's, with the last session for this afternoon. And, oh, God. Okay. Don't let her do that to me, okay? Don't let her do that to me.
Are y'all having fun? Great. Well, you know, it's my goal to make this as fun as possible as well. So one of the things that's most fun for me about these summits that we do is that we just have tremendous response from some giants in the immunization world. And last night we had Dr. Offit, we have Dr. Alan Hinman in the audience today, who did some sessions for us. Tomorrow we have Dr. Hotez. But now I want to introduce you to a megastar in the immunization world, infectious disease world. And he is here to introduce our speaker for this afternoon. It's Dr. Herbert DuPont. Dr. DuPont is here to represent one of our sponsors, CHI. And he is, like I said, a giant in the immunization world. And we're just so thrilled to have him here to introduce our last speaker of the day. He is the director for the Center of Infectious Disease at the University of Texas School of Public Health. He is the Mary W. Kelsey Chair in Medical Sciences, UT Health's Medical School, professor at UT Health School of Public Health, and he serves as the infectious disease epidemiologist for the Centers for Disease Control and as president of both the Infectious Disease Society of America and the National Foundation for Infectious Diseases. I told you, giant. Dr. DuPont is the author of over 650
She's the speaker.
I know, but you're Dr. DuPont. 650 scientific papers and 19 textbooks. Do you ever sleep? He can discuss Ebola, influenza, travel medicine disease outbreaks, intestinal infections, acute diarrhea, foodborne illnesses, and norovirus, as he was one of the researchers who discovered the virus. Please help me welcome the famous Dr. DuPont.
Thank you. Now I'm going to talk about pertussis, Flor. Actually, on behalf of Catholic Health Initiative, St. Luke's Health, and Baylor St. Luke's Medical Center in Houston, I'm just terribly delighted to introduce Dr. Flor Munoz. Dr. Munoz is a friend and colleague. She's a national leader in pediatric infectious diseases. She works both at Baylor College of Medicine and Texas Children's Hospital. She's worked on a number of important viral and bacterial vaccines, primarily working through the Vaccine Treatment and Evaluation Unit funded by National Institutes of Health, of which Baylor is one of the partners in that program. She oversees the infectious disease program and the solid organ transplantation unit at Texas Children's Hospital, and she's going to talk to us now about pertussis trends and challenges. Dr. Munoz.
Well, good evening, everyone. It is my pleasure to be here, and I am humbled by this nice introduction and the people who have introduced me today. I am just someone who definitely believes in vaccines and believes that no children should be suffering from any vaccine-preventable diseases. And what I would like to do today is talk to you about one of those, pertussis, which has been really in my radar for over 10 years right now, and of which I've learned quite a bit over the years. And so I have no relevant disclosures for this particular topic. And I have decided to talk to you today about the epidemiology of pertussis. We'll talk about the US and also Texas data, of course, because it keeps changing. This is one of the organisms, one of those diseases that keeps challenging us, infectious diseases specialists, but also pediatricians and anyone who works in vaccines to really do better at controlling this particular infection. We will talk about the current prevention strategies and what the updates are on those, and specifically one of my favorite topics, maternal immunization. And then where do we go from here? Because of the issues related to the need for a better pertussis vaccine. So some of these might be a little busy, but don't worry, I'll tell you all about what they're saying. Just as a very brief introduction, some of you might have seen whooping cough, pertussis, because it is very common to see now. And as you know, it's a very characteristic illness when it presents as the textbook says. It tends to start with a coughing illness, just initially actually with a runny nose, just like the flu. And then it progresses to the more typical coughing type of illness where you have a paroxysmal cough that is not just any cough. You know, people ask me about that. It's actually an uncontrollable cough. You have people of all ages, from infants to adults, cannot stop coughing. And this is why eventually you hear that whooping sound that is very typical of pertussis, because you run out of breath. And then you have to catch your breath. So that's classic. Otherwise, you have vomiting, and sometimes in young babies, they stop breathing just because it's so hard to catch their breath. And what is important to know is that it's not just a disease of children. We have learned through the last couple of decades that pertussis can affect people of all ages, from children to adolescents to adults. And actually, one of the first changes in the epidemiology was the realization that adults do get pertussis, even if they've been vaccinated before. And you see that worldwide it is a very important disease, with millions of people affected every year and almost 250,000 deaths reported annually from whooping cough. Now, babies under 6 months of age do have the highest morbidity, so they do get sicker, and they do tend to have more complications and death associated with pertussis. But we do focus as well on the adolescents and the adults because they are the reservoirs. So many times, adults who are coughing and they just have a persistent cough for many, many months don't realize it, but they have whooping cough, and they can be passing it to others that are susceptible, such as babies. Now, this is one of the updates already. This is from the CDC. As you may know, pertussis, whooping cough, is a reportable disease, and it is because it's a very contagious disease. If you have one child in the household of others that are susceptible because they're not vaccinated or they haven't had pertussis before, up to 80%, so 8 out of 10, will have whooping cough because of one case in the house. Very contagious, so it's important to notify when you have even a suspect case. But these are the definitions. You don't need to have laboratory confirmation. All you need to do is to have a clinical presentation that is consistent with pertussis. Usually, a case that is a probable case will be considered to be someone that has a cough for at least 2 weeks, and then the classic paroxysmal cough, whooping sounds, and then pertussive emesis. And it is a confirmed case when you have any of those symptoms, particularly the cough of any duration, with either a positive culture or positive PCR. And so we use PCR these days a lot more. We also consider a confirmed case those who have the symptoms and are contacts of a confirmed case. And then one revision for this year about the definition of pertussis for infants is that the CDC has included, in addition to the paroxysmal cough, the whooping sound, and the vomiting, the presence of apnea in and of itself in infants is also a characteristic that would be consistent with pertussis, and it's enough to consider a case as a probable case of pertussis. Now, again, anybody that has a positive test and has cough of any duration, it could be just a couple of days, it could be more than 2 weeks, then that would be a case as well. So that's new. I do have several images of CDC figures to show you, but because again, it is a disease that keeps challenging us. When I started working on this about 10 years ago, we were saying that the number of cases reported, this is just the cases that tend to actually make the books, not all the cases that are occurring, were actually similar to those we were seeing in the 60s. Well, now, a decade later, we continue to have higher and higher number of cases reported. 2012 was the highest number. Almost 50,000 cases were reported in this country of pertussis, which is similar to what was seen in the 1950s in this country. So no matter how we see it, definitely there is an upward trend to the number of cases that are occurring, even though it continues to be a cyclical disease where you have epidemics that last a year or so, and then little periods of less activity, and then 4 or 5 years later you would see another epidemic. So you see we are, 2013 was a little bit less, nevertheless the base continues to go up. And where are we this year in particular? This is most recent data from the CDC. So far we're about 20,000 cases in the US, which is about half of what it was in 2012, but it is 30% higher than what it was last year at this time. So you see that it continues to happen, and that map shows you the states where there is more pertussis. The darker green are those where there is more pertussis this year than the year before. And you see, for example, California is listed there. And California had a terrible outbreak in 2010, and this year they've already declared an epidemic because they have already more than 8,000 cases reported and at least 1 death. And Texas seems to be with not a lot of change, maybe a little bit of a decrease compared to last year, but we nevertheless see quite a bit of cases. I wanted to point out who gets pertussis. So we've talked about all ages, but this figure shows you the distribution by age. So that the top pink line right here is that of infants under 1 year of age. And you see that clearly it's infants under 1 year of age who will have the highest incidence rate. So per population, more cases of pertussis in that particular age group. And although all the ages are increasing, one point that I wanted to make about this particular figure is that you see the orange line where there has been an increase, and this has actually, after 2006, across the lines of the adolescents, 11 to 19 years of age, and even the children of 1 to 6 years of age, and it's going up higher. And this age group is the 7 to 10-year-olds. And we will talk about this a little bit more, because this is one clear change right now since the introduction of the acellular vaccines for adolescents, that we are protecting teenagers. With the acellular vaccines for children, we are protecting the young infants and the children who are vaccinated, but those in between, the 7 to 10-year-olds, seem to have a little bit more disease, and we'll see why in a moment. When you look at the incidence of pertussis by age and also by race, ethnicity, very interesting phenomenon. I talk about pertussis in different places in the country, and here in Texas, I have figures that look just like this for Texas Children's Hospital, and other people in other states see the same thing, which is that clearly in the first 6 months of life, you do see more disease, and you see a predominance. The red bar here in their year of age is Hispanics. But after that, you see 1 year to 6 years, and even adolescents, then it changes. It's no longer Hispanics in which you see the highest rates of pertussis. It's actually the white non-Hispanic population, Hispanic second, and then African American as third. And so this is very interesting, because I don't think we understand yet why that is. But for those infants, especially that have the highest morbidity and mortality, there is an overrepresentation of Hispanic, no matter where we are, not just Texas or California, but throughout the country, I'm sorry. And then this is really the bottom line of why we continue to worry about pertussis, because it might be a self-limited illness in adults and older individuals, but for the babies, it could be fatal. And these are the numbers of deaths that have been reported in the United States since the year 2000 up until 2013, the most recent data. And the blue part of the bars is babies under 3 months of age. So 2 points to remember from this slide is that every year babies do die from pertussis, a vaccine-preventable disease in the United States. And number 2, that it's the babies under 3 months who are too young to be vaccinated who have the highest mortality. There are a few cases, as you can see, in those that are over a year of age, but it's not very common. Those would be usually individuals that have comorbidities or other problems. And I wanted to bring you back to Texas. So you remember the figure with the peaks and valleys that we see throughout the country. Texas is matching that. We seem to have a little bit of an overlap, but not quite, because, for example, 2010 was a big year for California. 2012 was one of the big peaks. For us, it was 2009 and 2013. And you see that actually the highest number up until last year was 2013, with almost 4,000 cases reported. But the similar trend. So we see what the nation sees. And you see again, for 2013, the State Department of Health reported almost 4,000 cases. That surpassed the highest peak that we had before in 2009, as you saw in the figure. And then we had 5 pertussis-related deaths. You'll start seeing a pattern here, because clearly these were all under 3 months, so too young to be vaccinated. And then what is sad is none of the mothers of those babies had been vaccinated, even though in 2012, we started with the ACIP recommendation of vaccinated pregnant women, because we know that babies are born with too little antibody from their mothers. And that was the reason for the recommendation, as we will see in a moment. From 2012 to 13, 48 deaths have been reported in Texas. And as you can see in 2014, this is data that I was waiting for, was just posted this week in our health department website. A little bit over 2,000 cases reported so far as of November 3rd. 2 deaths, and as you can see, one was a baby under 2 months, and the other was a teenager with comorbidities. Again, 2 years after the recommendation, this baby under 2 months who died in Texas this year, mom did not receive the vaccine. This is what it looks like, just to give you a very brief image. The higher dense areas, metropolitan areas, is where you see a lot of the disease, and this is 2013 in the blue, 2014 so far this year, very similar distribution. Now let's talk about the prevention strategies. And I mentioned to you, we've had this realization since the late 80s to 90s that we are seeing more and more pertussis despite vaccination of children. And you might recall it was 1997 where the change occurred from the whole cell pertussis vaccine to using a cellular DTaP for children. So that was the 2, 4, 6 doses within the 18 months and the 4-year boosters. And that change, as you recall, was in response to concerns of reactogenicity, fever, seizures, things like that. So a safer, less reactogenic vaccine was introduced in 1997. It was several years later, in 2005, again, in response to the fact that we had more cases in adolescents than we had seen before, a adolescent vaccine became available. So that is the Tdap, that has less diphtheria, less pertussis, but the same amount of tetanus in its components than the infant vaccine, and therefore is less reactogenic even, so we can give it safely to people over age 7. And shortly after that, in 2006, the recommendation for adults became available so that all adults would receive at least 1 dose, and that recommendation is still in place, particularly healthcare personnel. And surely at that point, one question was about tetanus exposure, and the preference was to use Tdap at the time. So all these remain in place, and they were introduced, and as you will see, they were implemented in different rates. But we still had pertussis. I just showed you the figures. So in 2008, especially given that high mortality that we have in infants, a decision was made by ACIP that maybe we should try to prevent disease in moms and try to protect the babies that way by vaccinating women postpartum. So that was 2008, was the first time that this recommendation came in place. And by protecting moms and all the close contacts of the babies, the idea was the babies shouldn't get whooping cough. Even breastfeeding moms could get the vaccine. Problem is that it was really difficult to implement. Some of you might have gone through that. How do you get to vaccinate mom? How do you get to vaccinate everybody? This cocoon strategy, although made sense, turned out to be a challenge. And it turned out that actually it might have been too late by the time you vaccinate moms postpartum to really have an effect in protecting the babies. Because we've learned also that for the most part, infants, when they get pertussis, usually present in the first 3 weeks of life, and that's because they were exposed very, very early in life. And so by vaccinating moms postpartum, it takes at least another week for antibodies to start working. Therefore, there is a period of non-protection, and most of these moms anyway, or fathers, would have been sick before the baby's born. So it was probably a little too late. Therefore, in 2011, since we had more and more mortality, the recommendation was made to vaccinate women when they were pregnant in their 2nd or 3rd trimester, and to do that if they hadn't received Tdap before during adolescence, since by then there had been already 5 years of this use of this vaccine. And then at that time, this is right after the California epidemic, this is when it was realized that we shouldn't worry about the interval between TD and Tdap. It doesn't make a difference in terms of reactogenicity. You can do them, it doesn't matter when. The importance is to give the Tdap so that you have protection for pertussis. And then that people over 65 then became part of the recommendation because it was realized that grandparents do get whooping cough too. They can be sick and they can also pass it to their babies. So this was 2011. And then what happened, if you remember the figures I showed you, 2012 was that huge year with almost 49,000 cases of whooping cough reported and high infant mortality. And that's when ACIP said, that's it, we're going to vaccinate all of the mothers every pregnancy, regardless of whether they've had Tdap or not. And that recommendation stands right now, and this is what we should be doing. And I'll bring you back to that a little bit later. Now, I am going to talk very briefly about this resurgence of pertussis and questions related to the vaccine, because we might be thinking, oh, maybe we didn't do the right thing by using an acellular vaccine, and that's why we have this problem. And there is some to say about that. Nevertheless, I don't want you to think that the vaccine doesn't work, because it does. And what we've seen, these are numbers from the CDC, that we have high coverage rates in this country. The first box on your left top corner, I guess, is the infant immunization. So this is infants up to 3 years of age, where at least 3 doses are given to over 85% of children, a little bit less for those that actually receive 4 doses. And that depends state by state, it varies. But it's at least 80 or 85%. It's pretty good. In adolescents, which is the second box next to that, the coverage has increased significantly. And actually, this is up to 2011, but the numbers for the most recent year, 2013, just came out, and we keep going up. It's 86%. So we're doing really good with Tdap vaccination of teenagers. For adults, though, that's the bottom box right here, is not that great. And adults are still lagging behind. We have numbers there for 2011 of about 17%, 15%, and that number is very similar right now. So you see, adults, we still need to do a better job. And what was noted, this was as of 2012, before the vaccine recommendation for pregnant women became available, was that before and after the use of the Tdap, there hadn't really been a change in the incidence of pertussis among infants. So infants continue to have disease, even though we were vaccinating all of those around them. Another reason why maternal immunization made sense. And I wanted to show you this in a figure again because the uptake changed. So higher uptake on the top bar with the children 3 doses, 4 doses a little bit less. When Tdap was recommended, a very, very high uptake for adolescents, but again, the adults were a little bit behind, still right there. And so these were the initial strategy, which is let's vaccinate everybody because everybody can get pertussis with at least 1 dose of pertussis vaccine, and hopefully that way we'll see an indirect effect in protecting the babies, and we've learned that that's not the case. Now, I wanted to show you in sequence these 3 figures so that you can also see the change in the epidemiology of pertussis as we keep introducing these interventions. So when we had the acellular pertussis vaccine introduced in 1997. There was a cohort of children that had received some of the whole cell vaccine and some of the acellular vaccine. And then after that, a transition period, where both were being used. And then we went on to directly just the acellular vaccine. And so in 2004, before the adolescent vaccine was available, this is what we were seeing, a lot of cases in adolescents. And those were the kids that were, when they were younger, they were receiving a combination of the 2, okay? And this is why we introduced the Tdap vaccine for teenagers. But not a whole lot of disease, at least in the younger age groups, although we still saw some of it. Move forward to 2010, and you immediately see a change. We introduced Tdap for adolescents, and guess what? They actually have a decrease in pertussis in teenagers because Tdap does work. But we start seeing that the cohort of children that had received only a cellular vaccine in infancy are those kids that are making that initial figure that I showed you at the beginning cross the lines and start going up. And it is the 7 to 10-year-olds who are having more pertussis. And that's already giving you a hint that that acellular vaccine, although was good at protecting them early when they were receiving it in the first 3, 4, 5 years of life, by the time these children reached 7 to 10 years old, it was probably not as protective as you wanted it to be, because that's why we had more cases. And then 2013, these are 2 problems. We continued to see the 7 to 10-year-olds, and then again, some disease in the adolescents. So the bottom line, and I'll show you a little bit more of data, is that the duration of protection of these acellular vaccines is actually less than what was originally expected. So normally, you would have expected at least 5 to 10 years of protection. Keep in mind that even natural pertussis disease, so if you get whooping cough, you don't have protection for life. You get protection also for about 6 to 8 years. And this is why we see those cycles in the population. And this is why we see that adults of any age can still get pertussis. We just don't get as bad of a disease as the babies. But the vaccine also will give you a shorter period, a relatively short period of protection. And in this case, it has become clear that the acellular vaccine seems to be not really the 6 to 10 years, but maybe 3 to 5. And that's why we have these cases in this population. Okay, so these are very, very small print. I don't expect that you'll see it from the back, but just to summarize the issue on effectiveness and make the point that the immunity does wane within 3 to 4 years. When the initial studies were done in 2005 of the effectiveness of the This is Tdap, adolescent vaccine. In teenagers, it was estimated to be about 85%, which is similar to the infant, actually, whole cell vaccine. But if you look at the studies that progress, what's here is 2005 up to 2012, then the effectiveness was down to about 66%. So only 2 out of 3 would be protected after about 3 to 5 years. That's Tdap. This is another study also looking at protection over time. And just to be a little bit more clear, this is children that received Tdap doses compared to those who didn't, about 63% effectiveness. All right, so that's what we can quote. You have that protection, but that also varies over time. So the duration, if you have a measurement within a year, is going to be higher, 73%. At 2 years, it's going to be about 55%, and after 2 years to 5 years, it's about 30% in this particular study. So waning immunity is definitely a reason we are seeing more pertussis. This is Tdap in adolescents. These are some studies that have been published because that was a question always about how long does it last. So I just wanted to show you that for all the vaccines that are available for adolescents in the US, there are ongoing studies, or there have been ongoing studies to see how long the protection lasts. And I don't know if you can see this very well, but this is just one of the vaccines, and clearly this shows all of the different antigens, PT, FHA, Protactin, and Fimbria, which are the antigens in the vaccine, and how after vaccination, clearly the levels go up, but after about 2 years, it comes down, and then it's kind of slowly, gradually going down after that. So what we're seeing in terms of the effectiveness, meaning how many cases are happening, does match the measurement of the antibody over time as it actually decreases after vaccination. And this is true, again, for both Tdap vaccines that are available in the US. Important to remember, though, we don't have a correlate of protection. So we don't really know how much antibody we need to have protection for pertussis. We just know that after vaccination, it goes up really high. And then, what is the lowest that we can tolerate is not very clear. And the only way to know that is with vaccine effectiveness. Okay, and then I wanted also to point out that studies have been done for both Tdap vaccines that are available in the US to demonstrate that if you do give a booster, so you give another dose after a period of time, in this case about 10 years after vaccination, this is for young adults, you have an increase in the antibody concentration. So the antibody concentration goes down, but it doesn't completely disappear, and you do boost. So if you had either a natural infection or a booster dose, the levels will go up again and you'll be protected again. Okay? Now let's talk about infants very briefly, and again, this is very similar, even if you don't see the little numbers that I have there. The idea is the same, that when you look at the original effectiveness that was expected after 5 doses, so that is completing the primary series and then the 2 boosters in the babies with DTaP, you would have about an 85–88% protection or vaccine effectiveness. But as time passed, this is by 5 years of age, it's about 70%, so it decreases over time, same phenomenon. And one important message that I want to give you, because again, these vaccines do work, even though the antibody goes down over a period of time. This is a figure that comes from a study done in California where they look at hospitalization. And what you see there in the line is the number of cases of pertussis, so the incidence rate. And you see this in age in months. In the first 2 months of life, you have the highest incidence of pertussis, especially in those that are not yet vaccinated, because we start at 2 months. But even 1 dose of the vaccine starts making the curve go down. 2 doses, you'll have even also more. So 2 doses is this next gray bar, and by the time you get 3 doses, which is the hash bar, you have a much lower incidence of disease. So that primary series of vaccine in the infants is protective, and 1 dose is better than 0 doses. And by the time you get the 3rd dose in, you have a very good chance of having that baby protected in the first year of life. And this is why it's very important to make sure these babies do get their vaccine on time, and making the message to the parents that alternative schedules or delayed schedules are not in the best interest of the baby, because we do have this evidence that it protects. That's the highest risk period as well. And this is just, again, more data to show for the DTAP, the incidence of cases. Again, waning protection, this is, I already showed you that numbers of cases that are occurring after age, so higher number of cases of pertussis in 9 to 10-year-olds. So we know that by the time these children are 7, they're going to be at risk again. They need that 11-year-old booster also on time. All right, one more message here, that if you do give that booster, they will have protection, okay? So this is in teenagers who had received either a cellular vaccine versus whole cell. And it is true that if you had a child, a teenager who had received initially all whole cell vaccine when they were infants, and you gave them a booster of Tdap, the incidence of pertussis, here's the percent positive, is relatively low, 3.4%. And if you have a child that had received all acellular as a child and then Tdap as an adolescent, a little bit higher, about 18%. But what is important to know is that if you don't boost them, there is a risk of almost 10 odds ratio that they would get pertussis. And if you do boost them, that is dropped to at least half of that. So given that, adolescent vaccine is very important. Okay, so that's my big information about immunity, because I think that what has been in everybody's mind is what have we done by introducing this less reactogenic vaccine. There clearly has been a change, and it has to do with the fact that duration of protection is less. But an important message for you to take home is that both the cellular vaccines that are available do result in high levels of antibody that are protective against disease, and that we do have a very long period of protection where these children and adolescents are protected. We also have to understand that the type of immunity that is elicited by these vaccines is a little bit different, and we are trying to still continue to understand what that means in terms of Th1 versus Th2 responses in the long term. But it is immunogenic and it is protective. Now, you've heard also some questions about, should we be giving boosters to everybody? Should we be getting every 5 years or every 10-year vaccination? And CDC, just as of last week at ACIP, decided that's not the case. We're not going to give vaccines to everybody every 5 or 10 years. And the main reason is because that duration is too short, and it's just not practical to be boosting everybody every 5 years. But you would see that you would have some high-risk populations, as we will discuss in a moment with pregnant women, that in whom it's important to keep those levels high to protect the babies. And so that is still a consideration. But as of now, the main reason we don't give repeated boosters is because that duration is too short, and also cost-effectiveness issues, I guess. So the current strategies: on time, on schedule. You see how important that is. Improving coverage in adults. As you saw, the numbers are less than 30% of adults, less than 1 in 3 of 10 have the vaccine. And then maternal immunization. So it's recommended since 2012, and I am very sad to tell you that less than 1 in 5 pregnant women are getting their vaccine. I'm also very sad because I just showed you the case in our state, in Texas, that died this year already, of an infant whose mother was not vaccinated. So we would need to do better at that as well, and that is probably the most important strategy right now. This is what ACIP also has decided last week. We need to continue our efforts with maternal immunization, and I'll show you why in a moment. But after it was adopted here in the US, the UK also did that, and Australia did that in 2012. Other countries are not necessarily as widely using it as we are, but in certain risk areas or during epidemics, they will do vaccination of pregnant women. And it is indeed the most direct and the most effective way of protecting the babies. So I wanted to show you this. It was mentioned that we do some research on maternal immunization, and this is a study that was very important to me and to the people I work with. Because we tried the concept of vaccinating pregnant women with the Tdap vaccine before it was recommended. This study we just published in JAMA in May this year, but we actually did the study from 2008 to 2012 before the Tdap recommendation became available for pregnant women. And we did this because we knew that we were heading that direction, yet the CDC wanted to have some information about the safety of the vaccine in pregnant women, whether it actually elicited antibodies. There's this misconception out there that pregnant women don't respond to vaccines because their immunity is changed. As a matter of fact, that's not true. Pregnant women do respond to vaccines really well. And then we wanted to see how well the antibody went from the mom to the baby through the placenta and how much antibody those babies had. Also, the CDC asked us to look at whether there was any interference of maternal antibody with the baby's active immunization. So I'll show you a little bit about what we found. This is what we did. I already told you that. The study was very ingenious design. Remember at the time, this was 2008, the recommendation was that women should get their Tdap vaccine postpartum. So we couldn't just not give the vaccine, okay? And so we designed it so that we had actually 3 groups. Our main intervention group was pregnant women. We had, in the end, actually 33 of them who received the Tdap vaccine when they were pregnant. And then, in order to keep them and the rest of the participants and us, the investigators, blinded, we gave the comparison group, which was pregnant women, also at the same level of gestation, which was 30 to 32 weeks of pregnancy, a saline shot when they were pregnant. And then when they delivered, we crossed over so that those who received Tdap received a saline shot, and those who received saline during pregnancy received the recommendation at the time, which was the Tdap postpartum, okay? So at the end of the study, every woman who was pregnant did receive Tdap vaccine either during pregnancy or postpartum. And we also compared our participants with a group of just non-pregnant women that served as controls as well. And then it's a long story short, again, you might not be able to see this, but one of the main issues is reactogenicity. And we do worry about local reactogenicity, but in pregnancy, mostly we do worry about any anaphylaxis or any type of high fevers that could affect the pregnancy or the fetus at some point. I'm happy to tell you that the vaccine was as reactogenic as we expected, both for pregnant women and non-pregnant women, so that actually pain, which is the top line right there that I have signaled, was present in about 75%, 73%, and 78% of women who received the vaccine during pregnancy, postpartum, or non-pregnant. So basically, the reactogenicity is very similar. Whether you're pregnant or not, a Tdap might hurt just because there's tetanus in it. And it's about right. About 2 out of 3 people will have local pain. But when you look at fever, which was one of our concerns, it was very low. It was less than 3%. It was actually only 1 pregnant woman who had it. While in the postpartum group, we had 4, 26%, and 3, which was 9% in the non-pregnant. And it turns out that some of this fever we were seeing postpartum is postpartum fever, not necessarily associated with the vaccine, but very reassuring that when you give Tdap or you recommend Tdap to a pregnant woman, very low risk of any high fevers or anything. We didn't have any anaphylaxis, any allergic reactions, nothing like that. So the vaccine works the same in terms of safety and reactogenicity, whether you're pregnant or not. This is just to show you graphically, in terms of the severity of the symptoms. Here you have the injection site reactions versus the systemic reactions. And then in yellow is everything that was mild. Orange is things that were moderate, and red, severe. So injection site reaction, this is the group that received the Tdap during pregnancy, and this is the group that received it postpartum, and this is the non-pregnant women, and the figures look almost exactly the same because their reactogenicity is the same. While in this case, when you look at systemic, it's a little bit more blurry because even with the saline postpartum, women who are postpartum do have aches and pains and headaches and things like that. So they'll report that to us. It's not necessarily associated with the vaccine. So very safe. Another question is it safe for the pregnancy? So we wanted to make sure that it didn't result in any more C-section deliveries, and it didn't. Actually, we had fewer C-section deliveries in women who received the vaccine during pregnancy. Any preterm deliveries, small for gestational age babies, we didn't have more in the vaccinated group. And the infant's weight and APGAR scores, their physical exam, everything that happened at the time of birth, there were no signals, any increase in any concerns for the group that received the vaccine during pregnancy, okay? Now remember, this is a concept study. This was a total of 48 women who were pregnant who were vaccinated, not thousands of women. But we had an opportunity to take a look at that. What about the protection? I'll show you how well the moms responded, but first let me show you that the vaccine actually gets transported through the placenta very efficiently. This is what the placenta does. So what you see here is each of the antibodies to the different antigens. This is the top pertussis toxin antibodies, filamentous hemagglutinin, protactin, fimbria, and even tetanus and diphtheria. And we have the maternal antibody at the bottom, and then in the y-axis, the infant antibody. And it's a very nice steep line up, so that the higher the maternal antibody, the higher the concentration of antibody the baby will have. And what you see here in the red at the bottom is actually the group of moms who did not get the Tdap during pregnancy. They had the lower concentrations of antibody. That would be like anybody who doesn't get the vaccine in pregnancy. That's what they would have, yet whatever is there goes to the baby. It's an active transport process. But when we boosted that antibody in the moms, their levels went up, and so did the babies, in a very linear correlation. And probably the most important figure I have to show you here, and I'll walk you through that one. Maybe we can focus on the PT, pertussis toxin antibodies. I know it's a little bit small, but what you have here is each of the different antigens to pertussis. We have mother at the very first part of the figure, and then baby. And you see the first dot is the concentration of antibody of the moms before we gave them vaccine. The blue line is the moms who were vaccinated during pregnancy with Tdap. The red is the moms who were vaccinated postpartum. And you see that for all of the antigens, the baseline antibodies before we did anything were about the same. But the blue line for each of the different antigens in the pertussis vaccine goes up significantly at the time of delivery. And that is a statistically significant difference that moms did respond to the vaccine. And I'm not showing it here, but if you compare this antibody response in the pregnant women with the non-pregnant, it was actually the same trend, very similar. There was no deficiency in the immune system of the mothers. They were able to respond. Most importantly, like I showed you, the antibody went to the baby. So the first line that you see is the core blood sample, that in all cases, look how high for FHA, for protactin, for fimbria, up to, in some cases, 60 times higher than that of babies of moms who did not get the vaccine. So even though I can't tell you how much antibody is necessary to protect a baby against pertussis, because we don't have a correlate, I don't know that 1 unit or 10 units or 100 units are sufficient. I can tell you that if you vaccinate moms with Tdap during pregnancy, those babies are going to be born with many-fold higher levels of concentration of antibodies to pertussis than babies of moms who don't get vaccinated. And very interestingly, you see that you have that protection is lasting up to the first 2 months of life. That is a significant difference up until 2 months of life, which is the highest period of vulnerability. That's when we had that higher mortality in the first 2 months of life. And to answer the question that CDC had, we also were able to show that when you give the first 3 doses and then you boost them at 13 months, the blue line continues to go up. So these children do have priming. They do get primed with their primary series, and they boost when they get their 13-month-old vaccination, which is about 12 months is when we gave it. So there's no interference or no significant interference in their ability to boost. And even though the concentration of antibody might be similar at 7 months or maybe even lower in some cases, like here, PT, a little bit lower in the vaccinated versus unvaccinated or postpartum, that difference is not necessarily clinically significant, and the trade-off is that you protected them in the first 2 months of life. So this study was very, very helpful, to inform that in concept it works. I didn't tell you that it actually prevented disease because we didn't look for that. But these people did. The UK, it's a fascinating story. They actually were able to implement this right after we did in 2012. And they are presenting here also this year their results in July about the effectiveness of a national campaign in their case, where in their system of medicine, every woman would be offered a Tdap vaccination during pregnancy. This is the uptake. So you know this is from the time they started until 2013 when they started following. And the uptake of the vaccine would be here, so that you see about 70%, 75% at the highest was able to get vaccinated of the pregnant women. Compare that to about 18% for us, not too good. And then the blue bars, at least 50% or so would get the doses more than 2 weeks before delivery, which is really important to make sure the antibody gets through. So with that, the UK was able to not only reach higher levels of coverage in their pregnant women, but they were able to show us that the vaccine works beautifully. So they confirmed that it transfers to the baby by showing that if you vaccinate the children, at least 7 days before birth, or depending on the type of coverage they assume, if they have a 62% coverage versus 50% coverage, the protection could be anywhere from 84 to 91%. So that's effectiveness against actual pertussis disease. So what they've seen is, regardless of the babies, whether less than 3 months of age or 2 months of age, you would have almost a 90% level of protection if you have at least a 50% coverage of the population. This is very impressive because this is their same type of figure, but here we have the UK data up to 2013. And yes, infants continue to have high disease, but in this case, that blue line, which is the babies under 3 months, are starting to cross the other older age groups, and they're going down faster than the older age groups because of this protection of maternal antibody in the first 3 months of life. So it's early. This is only the second year, and they're still working on it. But this data has been presented all over the world, and it's very encouraging because, indeed, the concept that we demonstrated has been put in action, and we see that these babies are having less pertussis if you vaccinate women during pregnancy. Very, very exciting. And they also have regenerated safety data, which is very important because you can't just say we're going to vaccinate everybody and not follow safety. This is inherent to having a vaccine available. So they just published this data as well. And as expected, the vaccine has been safe. This is in the UK. They have something similar to our vaccine safety data link. So they've started to look at about 20,000 pregnancies, about 30-year-old women. They vaccinate at 28 to 38 weeks of gestation. And they're looking at any adverse events that are happening in real time as they have this program. One of the main outcomes they wanted to make sure they looked at is stillbirths, okay? So the bottom line is no increase in stillbirths, no increase in any of the adverse events that they were looking at in a very active manner. They have this system called a yellow card, which looks for any types of complications after immunizations, and so far they haven't seen any increase in pregnancy complications since the introduction of this program. Hot data, very exciting data. It shows that the program would work. And this is just to show you the actual numbers. So we have some information in the US. The US Vaccine Safety Data Link started looking at this. This is Dr. Carbanda with the CDC, and her organization looked at data of coverage. Again, still low. We have to do better. And when they looked at some adverse events, they did see, as I'll show you here in a moment, a little bit of a trend of chorioamnionitis being reported, a little bit higher in women who got Tdap during pregnancy versus those who didn't, but nothing in terms of the others, and certainly no premature deliveries. So this is very preliminary, difficult to know what it means, especially because the definition of chorio is out there, is not there. But the point here is that as we are introducing these vaccines, we do have systems in place to make sure they continue to be safe and effective. Okay, I'm not going to go, well, maybe if I have just 2 seconds. This is monkeys, this is baboon data. I just want to bring out the message to you that there's a lot of work going on in pertussis. And this is very interesting because it will bring the message that we still need to learn more about this. In this case, they did an animal model in baboons looking at acellular pertussis versus whole tail pertussis vaccine, vaccinating the pregnant monkeys and then looking at their babies. And then they noticed that infants from vaccinated mothers definitely have more antibody. But what was interesting in this model is that when you look at the challenge, they challenged the babies after the moms were vaccinated. The number of pertussis bacteria or colonies that they had was very similar between the groups. So the babies can still get the pertussis in their nose, even though they will not get sick. So this is white cell count was very, very low, so they didn't get sick from it. So this is teaching us that, yes, we are introducing this vaccine for pregnant moms. The babies will be protected. They might be protected from getting really sick because they'll have antibodies, but we're not necessarily preventing the fact that they can carry the pertussis bacteria in their nose, so there could still be transmission out there, which brings the message we continue to vaccinate. That's very important. So anyway, lots of work happening. This is my last slide. I hope that I have shown you with a very brief discussion of the updates on epidemiology that we continue to have a problem with pertussis, and that we have had increased cases after the use of the acellular vaccines, yet these vaccines are immunogenic and they are effective. We have different factors that have been involved. We talked about the waning immunity. Keep in mind that we also have more awareness and better diagnostic methods, so we are discovering more cases. But we also have unvaccinated populations, and there's a lot of data out there in the outbreaks that are being reported throughout the country that unvaccinated groups tend to have a higher risk of whooping cough, and they drive some of these outbreaks. We also have to do better at covering those populations that need the vaccine, and then we need to continue to understand this pathogen and what we're doing. So short term, go back to maternal immunization. I hope I have given you enough information to be convinced that maternal immunization is indeed the best and most direct method of prevention of pertussis in babies right now. And long term, we definitely need better vaccines. There is a lot of work happening, and we will see that coming up in the future. Thank you so much.
So a rich set of data there. Reminder that you will have all of these slides available to you so that in your leisure, you can go through them, and at different times, different parts of this data I think are going to be important to people more and more. And what I'm going to ask you to do is when you go back through this data, what I want you to do is put it right next to the slides that you saw this morning from Dr. Lakey. And you will start to see in the calls to action that he asked you to take on: the education, closing the gap in Texas between the Tdap vaccination rate and the national vaccination rate, raising the level of vaccines for pertussis in Texas, again, to close that gap. When he started to talk about the importance of the education of parents, of adults, and caregivers, as well as healthcare professionals. When you look at his call to action next to this data, you're going to see things start to rise for you in your work and the work that you can do. Please join me again in thanking Dr. Munoz for all of this amazing data. Vaccinate pregnant women. That is the takeaway. That is the call to action. And how do you use this data to make that happen more? In addition to thanking Dr. Munoz, I want to thank all of our speakers for today. Thank all of you for the work, for the effort, for the time that you have put in today. I will see you at the Hotel Contessa at 6 o'clock for our reception tonight. And I look forward to you networking there and continuing to be in action. Have a great evening. I'll see you at 6 o'clock.